Thank you for that excellent talk. Our next talk will be by Dr. Brian Feingold, who's the director of our heart failure and transplant program at UPMC Children's and a professor of pediatrics in clinical and translational science. His talk will be entitled Post-Transplant Management and Planning in Fontan-Kreutzer, ICU Management.
Thank you. I hope you can all hear me. And I'm going to try to show my slides. I apologize for not being able to be present with you today there. Yes, thank you again. And I apologize for not being able to be there in person. The hospital is fairly busy today. I'm going to speak a little bit about, I took a little liberty with the title, and I'm going to speak a little bit about transplant considerations in individuals with a Fontan-Kreutzer circulation. I have no relevant disclosures to this talk. So as a way of an overview, I will speak a little bit about outcomes after transplantation for individuals with a Fontan-Kreutzer circulation. I'll review some of the related morbidities that these individuals face with respect to transplantation and their influence on transplantation, and then try to sum it up at the end and put it all together and maybe give a little bit of a perspective of what a transplant cardiologist is thinking about as they approach an individual with Fontan-Kreutzer circulation. So what do we know about outcomes after heart transplantation in these individuals? There's a recent review article published last year by some of the folks in Melbourne, and it was actually a very nice article that looked at a lot of aspects of transplantation for individuals with Fontan circulation. And they have a nice table in there that summarized many, if not all, of the outcomes survival studies for individuals with Fontan circulation who undergo heart transplantation. And so I attempted to, from that, summarize it a little bit further. And as you can see, there's at least 19 peer-reviewed publications from 2004 to 2021 on the topic, covering patient years. So patient Fontan, at the time of Fontan, 1986 to 2018. Patient ages at the time of the Fontan range somewhere between a median of 6 years old to a median of 21.3 across these studies. And obviously there are ranges that exceed that. And early mortality is reported to be somewhere between 0 and 28% for these individuals after transplantation, with late mortality being also in some ranges here, but about 60 to 90% at 1 year, and about 60 to 80% at 5 years, and 45 to 70% at 10 years across these studies. So I think, one of the natural questions, this is a very heterogeneous group of studies that we, that they attempted to review. And it's a good question to ask, is whether outcomes have improved over time in individuals with Fontan who undergo heart transplantation. And so this is a nice study out of the Pediatric Heart Transplant Society, which is a really major asset in the heart transplantation field that allows us to look at a lot of different questions about transplant candidates and recipients who are mostly children. And so they looked at this issue and found that indeed survival had improved. Looking on the graph on the left, I guess, is the early era from 1993 to 2006, transplants occurring in that range. And then the late era in panel B on the right, 2007 to 2014. And you can see that the survival curve is improved. And if you look at the point estimates at 1, 3, and 5 years, those numbers are generally better. And I believe this is a p-value of 0.02. And then moving on, though, I think it's also worth asking the question, are these groups the same? Is this apples to apples or apples to oranges? And there's some evidence, I think, when you look at, this is the table from that paper looking at the two different eras. You can see that in the later era, there seems to be there's some signal, I think, that maybe the group is actually a little bit sicker. It's hard to say for sure, but there's more individuals with PLE. There's a greater degree of them having failure to thrive, and more of them are listed, higher proportion are listed at status 1, which is the most urgent listing status. And so not entirely clear, but it's intriguing to see that both in potentially a sicker population or a more urgent population, that those outcomes have seemingly improved. Also in this paper, they looked at what were the top causes of death or the most common causes of death identified across these individuals and across the eras. And I highlighted here just the the most prevalent or fairly prevalent causes. So we have infection, rejection, and then this other category of other, which is a little bit lacking in description. And I sort of took this to mean that it was related to the great list of Fontan-associated morbidities. And I attempted to summarize the ones I could come up with and have read about and have learned about, but I put an asterisk here because certainly this is not a complete list, and we're learning more and more about the morbidities that these individuals face. But as you can see, this really spans the gamut of morbidities across the spectrum. And I think a number of the other speakers today will touch on some of these topics. And so I'll come back to this a little bit, but I won't go in depth. So if we come back to infection, though, for a moment and focus a little bit our thoughts on that. So why do individuals with Fontan have infection seemingly more commonly after transplantation? And I think the etiology for this is unclear, but probably is multifactorial as well, and probably includes a number of these factors I've listed here, including many of these individuals have a neonatal thymectomy at the time of their early congenital heart disease surgery. Many have lymphatic leak or develop lymphatic leak over time, PLE. And with that, you have lymphopenia and hypogammaglobulinemia. And so that would potentially predispose to infection. A number of our patients, unfortunately, when they come to transplant, are malnourished chronically. And so that would obviously impair wound healing. And then, of course, chronic steroid use for treatment of PLE can also potentially exacerbate the lymphopenia and perhaps make infection more common. There is at least one publication looking very recently, it was published earlier this year by the group at Stanford, looking at risk of infections in individuals with a Fontan who undergo heart transplantation. And this is their baseline characteristics for this group. And you can see that they compared these 26 Fontan individuals to 33 individuals with dilated cardiomyopathy as their indication for transplantation. And so again, just even on this list, we see here that heterotaxy, history of protein-losing enteropathy occurred exclusively in the Fontan group, as well as at the time of transplantation, that their absolute lymphocyte count was significantly lower, as well as their serum IgG. So again, speaking to that lymphopenia and hypogammaglobulinemia that is unique or potentially exacerbated in this population. And they found that there's a higher infection rate at 180 days after transplant, with Fontan individuals having 54% of them having an infection versus 27% at 180 days in the dilated cardiomyopathy group. They were also more likely to have multiple infections by 30 days after transplant. There was a higher odds ratio for infection at 30 and 180 days in a multivariable model. And there was increased mortality from infection, it seemed, or at least a signal of this, where 4 of the 26 individuals versus none of the dilated cardiomyopathy individuals who underwent transplant died of infection or had a death where infection was related to it. So I want to diverge here a little bit and focus a little bit more on lymphatic leak. And again, I'm sure there are going to be have been and will be other great talks focusing on this, but I will sort of try to speak to the aspects that I think are pertinent to transplantation. Excuse me. And so this is a nice article also from PHTS centers that our center was a participant in. Dr. West, one of the panelists, is a co-author on this study. And it looked at Fontan-associated protein-losing enteropathy and outcomes related to transplantation. And this was a relatively small study where they looked at 52 individuals who had heart transplant and had previously had a Fontan with protein-losing enteropathy. The age of transplant is shown here at about 14, and the time from diagnosis of PLE to transplant was about 2.5 years median. And they did not find any associations of pre-transplant PLE duration or severity with mortality, which was 83% at 1 year post-transplant. And then found that resolution of PLE was near universal in this group, 98%, with a median time to resolution of about 1 month. Maximum time about 20 months, and 4 patients did have a relapse early post-transplant, but then resolved. And I would say this is parallels our experience here at Children's Hospital of Pittsburgh, and we have universally had resolution of PLE after transplantation. Moving on just to another lymphatic complication and its intersection with transplant is plastic bronchitis. And there's a very small set of patients who have been studied and published on this. Back in 2013, again, a group of individuals out of the PHTS, their center data. And so there were 14 patients that were listed for transplant with plastic bronchitis, and 10 received a transplant in this group. 2 died waiting. The early post-transplant mortality seemed to be fairly high, with 3 of these 10 individuals who received transplantation dying. And they all seem to have pulmonary complications, or one was described as having, frankly, having casts. And so it suggests that, that this is, you're not necessarily out of the woods right after the transplant happens with respect to plastic bronchitis. But once you get through that first 30 days, there were no further deaths out to 5 years, and all the casts, all the plastic bronchitis events and casts resolved by 20 days with no recurrences out to a median of 5.5 years. So I'm going to move forward and talk a little bit about rejection now. And I think it's worth just pointing out, though, that, thinking about rejection and infection as top causes of death are actually a little bit sort of disparate, or a bit of a paradox, right? Because when we think of the immune system and immunosuppression, somebody's immune system is functioning at a low level or is highly immunosuppressed is going to be more susceptible to infection, and somebody whose immune system is not adequately suppressed or is overactive, if you will, is going to be prone to rejection. So how can we have both of these in this same population be causes of top causes of death after transplantation? And I'm not sure, but I'm going to posit a hypothesis here, which is, again, many of these individuals, homograft use or allograft use, cryopreserved allograft use is very common in this population. Typically for arch augmentation for individuals with hypoplastic left heart syndrome, sometimes for PA patch augmentation. And this, we've known for almost 30 years now, is very highly sensitizing, causes marked degree of HLA antibodies to be present in that individual. And if they don't need a transplant, that's fine. But when many of these individuals come to transplant, that's a problem. And to explain why, well, these antibodies predispose to rejection. And this is historical data from the UNOS data set here in the United States. And that shows that in individuals who undergo a transplant, with the graph on the left, the survival curves on the left, with a positive cross-match, meaning they had antibodies already present, ready to recognize that graft as soon as it went in, survival was not as good. And that's the dashed line below on the left. Contemporary outcomes are a little bit better. The data on the right is from the CTOT-CO4 studies, which were done in part with our center and 7 other centers in the US. And it appears that transplantation across a positive cross-match, at least in the modern era, is no longer associated with an increased risk of mortality. And that may be because of changes and advancements in how we're able to treat it. But they still found that the presence of either early or late donor-specific antibodies, so antibodies that develop right after transplant or a little bit later in that first year, still were associated with added morbidity by way of rejection. One other aspect that's unique, I think, to patients with protein-losing enteropathy and Fontan prior to transplant is this phenomenon where they've received a homograft or an allograft distant in their history. They come to transplant a decade later, perhaps, or 15 years later. And we assess their blood for these antibodies and we don't see it. And they also happen to have PLE perhaps at the same time. And so they're hypogammaglobulinemic and are not maintaining steady state IgG levels. And so, this combination of maybe not having the production being ramped up because of the distant homograft exposure, the PLE causing this loss, allows us not to see those antibodies ahead of time, but we know to be worried about them. And so there's this phenomenon where they look like they're not sensitized, or they look like they don't have donor-specific antibodies to the organ that you accept for them, and then very quickly, within days of transplant. So that's not a production of new antibodies, because it takes 6 weeks to make IgG, 4 or 6 weeks. So this is within days of transplant, you see this marked blossoming of donor-specific antibody, unfortunately. And so this is really something that you need to be paying attention to and looking out for. And it's had a term either called an amnestic response or a memory response. And so it's important to be attuned for that in these individuals. Moving on. We'll talk a little bit about this other group again, which is to just say that there's a large list here. And so there's many more comorbidities that influence outcomes and survival and post-transplant morbidity after the surgery. And so it'd be great if somehow we could summarize this list into a risk prediction model or risk score. And I don't know that we're there yet, but also led by a number of PHTS centers and using that data. There was a recent publication last year in JTCVS looking at the liver and renal function. So basically using the MELD-XI score for individuals who have a Fontan and who are awaiting or undergoing transplant and looking at their outcomes. And so in this panel here on the right, you can see that regardless of how they're stratified, the green line being no VAD and no PLE at the time of transplant, and the blue line at the top being both VAD and PLE, so presumably a sicker population, that across the range of MELD-XI scores, a higher score is a worse is indicative of worse renal and hepatic function. You see that mortality on the y-axis here, 1 year mortality that's predicted is increased from anywhere from 9% up to about, I think this is about 25%, 23% for the most favorable group in terms of risk from a VAD and PLE perspective. And then this is actually outcomes data looking at individuals who were transplanted who had a high or a low MELD-XI score, and you can see that there indeed is a survival difference both early, and then it seems to continue on with further divergence of these curves late after transplant. So we're moving to conclusion here. I will just talk about one other area, which I think is a really important area and an area of emerging interest, and will be an area that we'll be focusing on more and more in pediatrics and borrowing from our adult colleagues, is the idea of or looking at frailty. This concept of frailty and trying to encapsulate that into our ability to understand the severity of somebody's debilitation, and perhaps as an area of focus to improvement. And so Kurt Schumacher, who's doing a lot of great work in the Fontan space and is really a thought leader here out at Ann Arbor, had this abstract as part of a group with this abstract presented at the AHA, I believe 2 years ago. A year before last, and they looked at frailty in pediatric patients and found that it was associated with impaired quality of life and increased hospitalizations. And so they looked at 54 individuals with a Fontan, median age 15 years, and they use a Freed frailty assessment, but modified it, and it encompasses the 5 domains shown there. 33% of these individuals were identified as being frail, and another almost 50% were identified as being pre-frail. And interestingly, they did not look at frailty with respect to outcomes in this work, but they did find that there was a very poor correlation of that Freed frailty score with the medical provider's estimate of frailty. So that's very interesting. So it suggests as providers, we look at a patient and we use the eyeball test, but it may not be telling us all that we need to be seeing about these patients and their degree of frailty. And then factors associated with frailty or near frailty included having PLE, having at least one hospitalization in the 12 months prior to the assessment for frailty, higher New York Heart Association classification, and more than 4 clinic visits in the prior 12 months. So these are factors you could start thinking about in your mind as you see your patients and decide whether they really are more frail than we're appreciating. So lastly, to wrap up here, I just want to speak a little bit about how, one approach or how I tend to think about risk in these patients and in all transplant patients, quite honestly. But, I think a transplant evaluation attempts to identify the risks that are present, unique to that individual, develop plans to correct or improve those modifiable risks where possible, and then determine whether in light of that remaining risk and what you can improve and what you can't, is it reasonable and feasible to proceed? And so I think of it as almost a risk budget. You think of like your budget and you decide where you're going to spend your risk and where you're not going to spend your risk, and you're just unwilling or can't spend your risk. And so, I think you can bolster your budget by the environment in which you practice and by your expertise and your surgical expertise and your ICU level support and your subspecialists when you have your gastroenterologists who are familiar with Fontan-associated liver disease, and you have your nephrologists who are familiar with severe congenital heart disease and heart dysfunction. That all helps you bolster your budget, if you will, and I think allows you to have a little bit more risk to spend, if you will. And so with each transplant offer, I think you need to consider those risks that are presented at the time by that candidate and at the time by the donor, and see if it fits in within your risk budget, and it's a go to proceed. After transplantation, we need to anticipate and manage those budgeted risks, and we need to be vigilant for the known but non-budgeted risks that are still probably going to pop up, even though you've done your risk calculation. So, and with that, I will conclude, and I appreciate your time and interest, and again, thank you for allowing me to speak.